All right, good afternoon, everybody. Thanks for joining us today for Mini Grand Rounds. Jared Moore is with us today, and he's going to be discussing tuberculosis. Thanks, Jared.
All right, thanks for joining us. This has been a topic that has kind of piqued my interest here over the past couple months as we have thought about different ways to try and more effectively and safely treat, in particular, latent TB in the resident clinic, and recognizing that there are many challenges in that area, but we need to get a better hold of what we're sort of facing, how to evaluate it, and then proceed on to how to actually create a system to be able to effectively treat patients who often have many barriers to treatment. So this talk is really going to focus largely on how do we go about screening patients, number one, and then sort of the overarching recommendations to treat all patients diagnosed with TB infection. And those are a little bit newer recommendations that have come out this year. From a screening perspective, this is going to be kind of broken into two components. The first component is going to be determining who we should screen, and that's based on certain risk factors. The second component is going to be how do we screen, and that's going to be based on patients' risk for progression to active tuberculosis, and so we'll walk through those steps. In terms of treatment, it's going to be a little bit of a flyby for this. There are a couple different regimens. We'll talk about them briefly, but won't necessarily be able to get into all of the details of that. But we'll be able to provide some more information after the session. I just don't think we have enough time to do all of this in one session here. So first, it's important to have a couple definitions for what we're talking about, especially as you're reading through the literature, because this can get a little bit confusing. TB infection often relates to either latent TB infection or active TB disease. Active TB is then also referenced as active TB, TB disease, or just TB. So that's a little bit confusing as you read through things, but really probably the most important thing, TB infection relates to both latent TB and active TB. We'll mostly refer to it as latent TB in that way, and then everything else is going to be active TB. So in general, throughout the U.S. as well as Ohio, which Ohio's in the blue and the U.S. is in the purple, we've seen declines in the rate of TB, this is TB disease, active TB, over the past decade or so. And these trends continue through Ohio as well due to increased surveillance, better mechanisms for treating. However, in Columbus and Franklin County in particular, we still see very high rates. This is from 2014. 2015 data is very similar to this. So while the rates in Ohio have overall decreased, we're still seeing pretty high rates here in Franklin County, so it's something that we all have probably come in contact with at some point, whether we know it or not. In terms of screening tests, one of the important aspects of this is that there is a window period. So we're going to focus on what are the tests, and then we're going to focus on who are we going to test. So with these tests, it's important to recognize that there is a window period about 6 to 8 weeks after infection. So meaning after you're exposed, if you get an infection, there's about a 6 to 8 week window before any of these tests are going to become positive. Therefore, if you have someone that gets exposed, you need to wait the appropriate amount of time prior to testing them to determine whether or not they actually have infection. And again, just to review that again, infection could be latent or active. Other factors which may contribute to negative TB tests are infants and young children. I'm not going to get too much into that here right now. But that's one area that can cause some false negatives when doing testing. Immunosuppression is, of course, another area that can cause false negatives with testing. And then overwhelming illness, actually due to tuberculosis or other infections, can cause false negative testing. So generally, we think of a couple of different types of tests. Most familiar is probably the PPD and this is a diagram of how to go about actually administering the PPD. It's just a small injection that we're familiar with that goes in between the epidermis and dermis and forming a small wheal. And then we're all probably familiar with measuring this. And again, this is just meant to be a reminder that when measuring the size of the response, we're supposed to measure the size of the induration, not the area of erythema, which may be something particular if your staff are doing these tests and they ask you to come in and check it. Sometimes we see that there's some inconsistencies in that measurement, so important to take a look at that appropriately, measure it appropriately. When doing the PPD, and here they have it marked as the 10 millimeter mark, they have different sensitivities and specificities depending on the size of the induration, depending on risk factors. There are tables that you can look up to see that. I'm not going to go into that in great detail in terms of which size of induration regarding which risk factors. But at this level, at 10 millimeters, the sensitivity is about 80% overall, and the specificity is about 97%. So this is really a pretty good test at this level. And that's what we're going to use when we compare it to the various interferon gamma tests that we're going to be looking at as well. I want to take a moment to just review the two-step PPD, just to remind people why we do this test and how it's useful for us. So assuming that there's an exposure and infection, again, infection could be latent or active, at some point in the past, years go by, and all of a sudden now we're going to do testing for it. We do a tuberculin skin test, and it's negative on the first test. Let's say they're in a position where we're going to repeat this maybe once a year or so. We wait a year, we repeat it. It's now positive. We now have this question of when did the infection actually occur? It could have occurred any time in the past year or any time prior to that. And if they're in a place of employment, hospital, something like that, they would want to know specifically when did that infection occur and did it occur while they were employed in that system, because that would be very important for infection control, other issues. So instead, we do the two-step. So again, years pass. The first one is negative. You would then wait 1 to 3 weeks. The first test can cause a little bit of boosting of the immune response. And so now when we do the second test, 1 to 3 weeks later, we get a positive test. Now we'll still have this question, when did the infection occur? However, what we know for sure is that it's not our fault because of the window period, because we know that that test can't turn positive for about 6 to 8 weeks. Therefore, it must have occurred prior to employment. Mm-hmm. Second set of tests that we frequently use are the interferon gamma, the quantiferons testing, or the T-spot TB. The quantiferon QFT GIT stands for the quantiferon TB gold in the tube, and the TB spot test is based on it's named after the way in which the testing is done, and it leaves a spot, and they actually measure the size of the spots and the number of the spots. And so that's the way that they get the name of that test. So this is a cell-mediated response. So these are the T cells. These are going to be coming from the patient. You're going to obtain a blood sample from the patient and their T cells, and you're going to put them in a tube that has TB antigen basically coated on the side of the tube. So it'll be an exposure of the T cells to the TB antigen. In response to that, interferon gamma will be released that is very specific to TB. These are very specific TB antigens that really have very little cross-reactivity with any other antigens present. And then they count the number, and they count it in reference to they count it in reference to other baseline measures from the patient's blood samples. And again, this actually has a sensitivity of about 80% and a specificity, again, greater than 95%. So fairly similar to the tuberculin skin test at 10 millimeters for the specificity and sensitivity. In general, this is important because it is easy to do. The patients can do it in one stop. They can get the blood test. They don't have to come back for repeat testing. The downsides are that it's more expensive and limited by the number of labs that may do that. There are higher rates of indeterminate for the quantiferon. There are higher rates of indeterminate results in children less than 5 or in patients with HIV and CD4 counts less than 200. And so as we go forward, we'll see that the quantiferon tests are generally not recommended for children less than 5. So we've talked about a couple of the different tests that are available for us. Now we're going to talk about how to actually approach screening, who we should screen, and what's the method that we should use to actually complete the screening. First, we want to classify, and again, this is another confusing area depending on which literature you're looking at, but it may be defined as increased risk for infection or likely to be infected. And it'll then break them out into different categories within that in different ratings. So these, I don't know if anybody knows this movie, Step Brothers. It's a wonderful movie. But close contacts, household contacts, or recent exposures to active cases are highest, what may be considered highest risk for having infection. Mycobacteriology lab personnel, so people working in labs working with this, are going to be the second highest risk. Refugees coming from high-risk places for TB, high rates of TB, are going to be sort of in the third category. And then actually in the lower category are going to be residents, employees of high-risk congregate settings, so prisons, homeless shelters. These are all kind of categorized in the increased risk or likely to be infected, although within those groupings there are clearly some people that are higher risk than others. Then there's sort of this no risk or low risk or unlikely to be infected. Those are also terminology that you'll see associated with the bottom grouping of risk. Falling within that are the people that will come in that say, I don't know, I just was told that I need to come in and get a PPD done or a TB test. I don't know why my employer is just making me do this, and they don't, but they don't really have any other exposures previously. Their employer is just making them come in to do this pre-employment testing, whatever that may be. And so there's different ways that we approach each one of those. So number one, we have to determine if someone should get testing based on their risk. That's what we just looked at. The next step is how do we go about actually doing the testing for these patients, and that's based on their risk of progression from infection to disease, so latent TB infection to active TB. And we separate that out into low to intermediate risks, which is categorized on the left, and then high risk categorized on the right. There should be probably no big surprises here in terms of how we would view this. The problem is, and we'll get to this when we talk about why the recommendation is that every single person with this should be treated, the problem is that anybody can go from low to high risk. Now, the risk for progression is greatest in the first 2 years after infection or after exposure. That's going to be the greatest time for progression to active disease is in the first 2 years, but these are other things that could put you at risk for progression later on, even after that initial time period. And so for that reason, it's recommended that anyone that gets a diagnosis, either latent TB or active TB, should undergo treatment. So that's a little bit confusing. So I've tried to create a little bit of a diagram that helps clarify practically how we can go about evaluating patients and making this diagnosis. So let me just walk through this step by step. So this is going to be increased risk for infection. That's going to be your first step to determine whether or not you should be doing screening at all. So these are the common factors that are going to put you at increased risk for infection. And we'll start off with no. Then is it required for employment? No, then just in the future you may reevaluate for risk. There's no set time period in terms of how often should you continue to reevaluate, but if someone subsequently has exposures, then that would be the time. Repeat testing or repeat that reevaluation. Yes. So current recommendations are actually to do the interferon test first, both because of convenience, sensitivity, specificity, all those reasons. The skin test can be used, but the current recommendation is to use the interferon first. If it's negative, you're done. You just reevaluate in the future. If it's positive, it's actually a high risk for a false positive, and therefore you actually want to do a confirmatory test with the opposite test. Now, there's some question about whether, and I don't fully understand this, but there's some question about whether the tuberculin skin test can somehow sensitize the quantiferon test later on. And therefore, by doing the skin test first, you may make it more likely that the quantiferon would be positive later. It's for that reason also that they recommend doing the interferon test first. That will not sensitize the skin test later on. So, again, if that's negative now, then you're done. You reevaluate in the future. If it's positive, you go ahead and treat, and you complete your evaluation for active TB. And we'll talk about what that evaluation is. So if you determine that, yes, they are at increased risk for infection, the next step is to assess their risk for progression to active TB, because that's going to determine, again, the decision pathway that you use to evaluate this. If they are lower intermediate risk, again, you use the interferon test. The skin test can be used, but the interferon is preferred. If it's negative, you reevaluate for risks in the future. Again, these people are people that are at increased risk. There's no set guideline for how frequently we should do testing. But for instance, if someone is in and out of homeless shelters, whatever it may be, that may be someone that you are screening annually because their risk continues to be there annually. But there's no set guideline for that. If it's positive, you again complete the evaluation for active tuberculosis. And then you would go on and treat that person either for active TB or latent TB, depending on your evaluation. The next, let's say they are high risk for progression, so that HIV, silicosis, young age. Again, you would use the interferon test. The skin test can be used. If it's positive, you complete the evaluation for active TB, just as you normally would. You assume that's a true positive. The problem is, for this group, missing a diagnosis is really high risk. So if they're already at increased risk for infection and increased risk for progression to active disease, you do not want to miss a potential infection. So the recommendation is to actually complete the alternate test in this population. So if you did the quantiferon first, you would, and it's negative, you would then go on and do the skin test, because you would say, I really am concerned that if you actually have this, that you may develop active tuberculosis, and I do not want to miss this. If it's negative, again, you go back through, you reevaluate your risks in the future. Again, there's no set timeline on which we should do screening, so that's a little bit up to your judgment, maybe every year or so. If it's positive, then you'd go ahead and complete the evaluation for active TB with the presumption that you will either treat them for latent tuberculosis or active TB. Okay. We'll post this. You will not find this on any, this is accumulated from several different documents, so I'll post this and we'll make this easily available for people to review and look at. So let's say we actually have a positive screening. What should be our next steps? First, get a chest X-ray. Hopefully, it does not show that cavitary lesion like we see here. But if it does, then they're going to go for further evaluation. Could they have active TB? This may have just been historical TB, but probably it's going to either go to pulmonary or infectious disease or potentially even the health department for treatment of active TB. Typically, that moves out of the realm of general medicine for us to be treating. A CT, sometimes this questions, when should we get a CT scan for screening? The recommendations to get a CT scan are if they are at higher risk, much higher risk for a variety of different reasons, maybe HIV, other immunosuppressing conditions, post-transplant. If you have a concern for active TB based on symptoms or other reasons, then it would be appropriate to go ahead and get a CT scan either after the chest X-ray or in addition to the chest X-ray, or as I mentioned, if they're immunosuppressed, then you'd get the CT scan. But in general, we do not need to get CT scans for everyone, only if they're in some of those higher risk categories. Next step then often is to get lab work, usually a CBC, chemistries, liver function test. That's important because most of the medications have side effects associated with hepatitis. HIV, again, because that's going to help risk stratify what types of evaluations we need to do if they are HIV positive, and then a chronic hepatitis panel, again, because that could put people at increased risk for having hepatitis related to the treatments. So let's say we go through all of this and we get to the end and we say, there's no evidence of active tuberculosis. I'm going to treat this person as latent TB. What is the efficacy of doing that and how do we approach that? Well, number one, if you test for it, you should treat it. So if you test for it and it's positive, you should treat it. The decision to test kind of already puts you down that pathway for treatment if you have the positive testing. So you should make that decision at the beginning of going through this protocol. So there's actually pretty good evidence showing that this works for latent TB, maybe a risk reduction of about 65% at 5 years for progression to active TB for treatment of latent TB. That's pretty significant. That results in about 52 to 150 cases of active TB prevented by doing that. Number needed to treat is about 111 to 314. Again, it's a little hard because we don't know the exact incidence of latent TB. And number needed to harm is about 279 to 2,500, and most of this is hepatotoxicity, particularly with INH. It costs about $500 to treat a person for latent TB, and it costs about $15,000 to treat active TB. Post-treatment monitoring, there are really no specific guidelines for this. There's no recommendations for ongoing chest X-ray monitoring, chest imaging, laboratory monitoring after you complete treatment. If they have newer symptoms again, then you may consider going through the evaluation process. Interestingly, there's some evidence that suggests that interferon tests may turn negative after a while. And Canada and some European countries are actually using this as one method to evaluate for effectiveness of treatment. And then if the patient gets exposed again in the future, you could repeat the quantiferon test. And if it's positive again, then you may assume that it's a new exposure, a new infection. That's not a current recommendation in the U.S. I'm not sure that it's necessarily going to get there. Ohio Department of Health has actually been wonderful in working with us over the past couple months in terms of helping us with protocols and some of the insight that they've gained in trying to treat patients both with active TB and latent TB. There's some question about who they're actually treating, and I think at one point we were able to get a lot of our patients with latent TB over there, and currently that's very difficult. Currently they're treating patients with active TB, active disease they're treating. Close contact of those with active TB, children with latent TB, so there's a big push to work through that with children. They have a large clinic there that's working on this. And they started taking a very small number of patients with latent TB, but I don't anticipate that that's going to expand dramatically. So probably a large portion of this burden is still going to fall on us. Occupational medicine, I'm not going to get too in-depth in this, but, you know, I think particularly in the resident clinic, but for all of us, we'll see patients who, refugees or immigrants that come through, and we'll have these diagnoses, and sometimes it's a little bit unclear what we should do. I think the message that we've heard very clearly from the Department of Health is that if anywhere in that occupational medicine note, sometimes it's a little bit difficult to find, but if anywhere in that note they say that they're referring them to the Department of Health, then we should assume that the Department of Health is managing the treatment and the evaluation process. Of course, we can ask the patient if that is true. What they've seen sometimes is, through our clinics, is that we've initiated some treatments and maybe that wasn't always appropriate to do in that setting. So they just really wanted us to know that if there's a note in the occupational medicine, if there's a message in the occupational medicine note that they're going to go to the Ohio Department of Health, then the Ohio Department of Health knows about them and they're tracking it and following them. So those are not the patients that we should be necessarily worried about having to treat. So again, our takeaway points here are screening all patients for increased risks. So this is screening all patients for increased risk. Our screening protocols change based on their risk for progression. But all patients with increased risk should be screened. And I suspect that we probably under-screen in our clinics, particularly in the resident clinic. I know that's certainly not one of the things that's at the top of my list as you're managing many, many other conditions. And then second, we should treat all patients diagnosed with TB infection. And again, infection is latent TB or active, obviously. And these are brand new guidelines that have just come out from IDSA, ATS, CDC, USPSTF, actually within the past 3 months. And finally, I just want to talk a little bit about what we're doing in the resident clinic. This has really been a large collaborative effort. Megan, pharmacist here, has been playing a big role in trying to help us organize this from a pharmacy perspective. We're working with our social workers and some of our chronic care managers and nurses to try and figure out a plan to do this. We've been working with the Ohio Department of Health and Dr. Xu Wang in infectious disease. And one of our current chief residents, Ashley Buffamonte, who's going to be doing an ID fellowship next year, is starting to work with us and to develop a really collaborative process. The goal is to recruit in patients that have latent TB and help residents manage them in their own clinics more effectively. So basically helping to get patients scheduled into their clinics, but providing residents with the true knowledge, protocol support that they need in order to safely and effectively do this, and then have the monitoring in place to make sure that we're able to capture patients who may be not returning as they're supposed to, but also helping them to overcome barriers with regards to transportation. We're trying to look to work with pharmacies to help potentially, we can't distribute any medications here, but a pharmacy can deliver them here to the patient when they're here. And we're looking to actually try and think about ways to coordinate that for some of these patients who are able to get here to an office visit, but may not be able to get to an office visit in the pharmacy due to transportation challenges that they may have. And so these are a lot of the things that the Ohio Department of Health actually does, and they have about a 93 or 94% success rate in treating patients with this, and probably some of the very similar patient populations that we see. So you'll probably be, particularly if you're precepting in the resident clinics here, you'll be hearing about this a little bit more over the next coming months as we try and develop these models to effectively treat this. Thank you.
Great. That was just a really succinct summary of something that is so complicated, and getting an update on it's really, really useful. And it is such a devastating disease that something we should be doing very, effectively. So I just have a real quick question, then we'll open it up. Let me unmute everybody's phones real quick. Nowhere in there did you mention age as any factor in a decision to screen or treat. So we have a lot of patients that, might be coming in as a refugee population. They might be in their 75, 80 range. You still screen those patients and you would treat?
The data isn't as strong in that age population, but there's no absolute contraindication. I think clearly you have to look at their individual risks for progression to active disease and also their comorbidity. So a big component of this is both treating the patient to prevent it, but also in terms of, from a population health standpoint, preventing the transmission of infection to others that may be around them. So I think it's has to take into account some of those components and what their risks for progression to active disease may be.
Because presumably they might have been infected in their 20s, 30s, 40s, and now they're, and you said the risk is highest in that first 2 years, so it's a little bit.
Right.
And can I ask another follow-up question? So can you get infected with tuberculosis twice, meaning can you get latent TB, get treated, and then 10 years later get re-exposed to somebody with TB and recontract it? Your cellular immunity doesn't prevent you from, does that put you into a lower risk category if you have a second exposure? Because you've already got immunity, presumably, to.
Yeah, I haven't seen anything, but yes, you can get repeat infection. I haven't seen anything that would say whether that risk would be lower. I don't know the answer to that, whether the risk would be lower, but you can get a repeat infection.
Okay. Well, let's open up to other folks' questions. Anybody in the room have any questions? How about folks on the phone? Do we offer, so as far as, we obviously offer which of those two tests, the quantiferon, it came by two different names.
Yeah, we have the quantiferon Golden tube.
The first one, okay, all right.
They're both pretty equal in terms of sensitivity and specificity, so it's.
But by and large, that should be our first test across the board, whatever scenario. So that's probably different than, so even when an employer is asking, we get those requests all the time, but they always say to do a PPD skin test as their primary.
So what I usually do is I order the quantiferon, I cross it out, and I put in the results as the quantiferon.
Okay. All right. Well, that's interesting. I mean, that's a lot less effort and work on our staff time, and the lack of follow-up and the timing is always tough, right? You get a patient on a Thursday or Friday, and then you decline to do it, and you have them come back in, which is inconvenient for everybody. So that alone is a big change that a lot of people don't probably know about.
What about employee health versus PPD still?
Yeah, employee health group here, so we still frequently get that. I haven't talked to Dr. Wang about whether or not we'll be changing in any way with regards to that.
What happens with cost for patients with their insurance and then where you choosing to do the quantiferon test?
So the question is about costs with regards to the quantiferon versus the PPD. I don't know the answer to that. The quantiferon is more expensive.
I mean, that's why I've limited sometimes.
When it first came out, it was $100 to do the quantiferon test. So I don't know how that compares to the PPD, considering the staff time. I mean, you do bill for all those other little pieces and parts. So, and sometimes you do it twice. So, right, it's a two-step. So.
Is the uncovered cost, is that the uncovered cost, or is that the, with insurance, that's what people pay on top?
Say the question again, Aaron.
Oh, for the cost for the quantiferon, is the $100 just the flat rate of the test, or is that the post-insurance rate?
My understanding is that's probably an average reimbursement from the insurance plan.
Most of the patients don't have insurance.
So I don't know what the patient cost would be. Obviously, it depends on the insurance plan and all.
But that's important. So, I mean, I think in all the recommendations, what they say is, excluding cost, all those other factors, quantiferon is the first test of choice when it comes to those issues of cost, and that we can try and get a little bit more information about that. But
well, here's what we'll do. I thought this was a great talk. We'll obviously post a video, and we'll post your slide deck, and what we might do is take that one slide that you have that's the summary workflow and put that as a separate little, you just click on that one link, it'll just show you that algorithm and that workflow. I think think a lot of people probably benefit from having access to that. So I'll try to get that up sooner than I normally do with other talks. All right. Well, thank you, everybody. We'll send a survey out around here shortly. Have a nice holiday.
You too.
Thanks, Jerry. Great.